Hello everyone. Now we are going to continue about the knots. So that is what we are seeing abnormalities of the umbilical cord that we are going to continue it. And in abnormalities in previous lecture, what we have seen about the abnormalities related with that of the content. That is what we are saying this single artery, that one, which normally umbilical cord carries the two artery, that is one. And second, what we are saying the abnormalities related with that of shape, that is what we are saying this Battledore placenta, where the placenta is umbilical cord arises from the margin, that is what we are saying in this. Then filamentous placenta, that's what we have seen. So now we are continuing about this part, that is the what are the different mm, abnormalities from the knot. There are two types of the knots, that is the true knot and the false knot. So what we have seen in this, see, this is the umbilical cord, whatever it is the Walton's jelly, and whatever this knot, it looks like it is not an actual knot, it is a false knot. And why this is appearing? And because it is result from the kinking of the vessels to accommodate the length of the cord, and are due to redundancies of umbilical vessels and of Wharton's saving. That is, as we know that inside of this umbilical cord, what it consists of? It consists of the vessels. That is, it consists of the umbilical artery, two umbilical artery, and single umbilical vein, which one is twisted one. But what happens? This sometimes it becomes the kinking and give appearance like a knot, but this is not the actual knot. That is called as a false knot. That is also a one an abnormality there. That is true knot, true, which that is the actual knot has taken place. And if we see the incidence wise, it is about 1 to 2%. Then it is more common in monoamniotic twins. So we are going to see about what are the different types of the twins. That is the active fetal movement creates true knots, and when the umbilical cord, it is the lengthwise, it is more than normal, that is 50 to 60 centimeter normal length of umbilical cord, and if it is more than that, it can lead to the false knot, true knot, and if there is active fetal movements, which can lead to that of true knot. And whatever the risk, what risk, if the true knot is there, what is going to happen? So there is a risk of stillbirth. What is meaning of stillbirth? If the fetus is born dead inside of the womb, then it is called, that is, death has taken place inside of the womb, that is in the uterus. So that is the stillbirth. And how much it is? It is the percentage increased about 5 to 10 points if there is a presence of true knots. Then FHR, that is fetal heart rate abnormalities, are common within the labor, but the cord blood phase values are normal in this. So that is what we are going to see. This in this diagram is in the actual knot has taken place to the umbilical cord. So can be it length, it is more, or it is length of the umbilical cord is more, can lead to this, or if there is an active fetal movement, can lead to this. Then loops, that is what I have already explained. That is the cord is frequently coiled around the fetus and most commonly around the neck. Then it can be coiled around the body also, but commonly it is around the neck. Then more likely with longer cords, but obviously it is going to take place in the, if the length of the cord it is more, that is normally it is what we know that it is 50 to 60 centimeters. And if it is more than that, it can lead to the loops. And these loops around the fetal neck are termed as a knuckle cord. That is uncommon cause of adverse PL outcome. And the contraction may compress the knuckle cord, that is the neck, if umbilical cord, loop around the neck, and cause FHR, that is fetal heart rate declaration, and low umbilical artery. And how much incidence? So it depends. The loops can be 1, 2, or 3. If the one loop, then it is one loop of knuckle cord. If there are two round around the neck of this umbilical cord, then it is two loops of knuckle cord. And third, that is if there are three loops around the umbilical cord, that is three loops of knuckle cord. And what is the incidence? Means out of 100 uh, loops, if you see that 100 cases of loops, so in that 20 to 34% it is first loop, then remaining 2.5 5% that is of two loops method called 0.2 to 0.5% of this method called cases can be observe it. So that is the see what is it we are seeing in this diagram? Yes, here that is this one is the umbilical cord and it is get round around the neck. That is loop. And the single is safer than multiple umbilical cord loops around the fetal neck. If it is more than one, so definitely it is more problematic situation. And if two types of cord loops around the fetal neck, that is type A and type B. What is then again the fashion is also two types. There are also number wise there are three types. If the number wise then first one, two, and three loops, and from the pattern wise that is type A, umbilical cord encircles the fetal neck in a sliding manner, and that is less dangerous. It does not have that much problem. While type B, where knuckle cord encircles the neck in a locking manner, definitely if it is locked, so definitely it is a very dangerous situation. And if it is sliced, then there is a no problem. That is what we have seen the types of the cord loops. That is type A, type B. And what is the management? What we have to do is at the time of birth, look for cord around the neck. And if it is loose enough for the cord to be slipped over the baby's head, if the cord is wrapped multiple times, then it may take some time. If what happens when if it is loose, then it loose enough for the cord to be slipped over the baby's head, it automatically slips. But if it's multiple times, then it takes a time. It takes a time. So in this diagram, at the time, if the cord is too tight and has to be cut before the baby is born, then if it is too tight, then it has to be cut. And the necessity is baby's birth rapidly since it is no longer getting nutrients from the mother via less placenta. So what happens if there is a too tight that does not lose? This is what we see in this diagram. There are two loops around the neck. At that time, if it is cord is too tight, then what you have to do is you have to cut it before the baby is born. But what is important, it is very necessary that you have to do the rapid action over here, and you have to do the baby's birth rapidly. Why? Reason behind it, the nutrients which is required for the fetus is no longer means if it is cut, so definitely it is not getting the nutrients from mother via the placenta. So what we have to do is immediate rapid birth of the baby that we have to follow. Then sometimes that is what we have seen. That is the torsion, not what we have seen. The look we have seen. Now we are continuing about the torsion and the structure. The torsion and structure. The torsion incidence wise it is very rare, but result from some fetal movements during which the cord normally becomes twisted. That is what we see that it is too much of twisting. Then that's why it is really important because inside of it there is vessels are present, and if too much of twisting it can lead to the compression of this. The people circulation is get compromised. That is why we are giving importance to this. And the stricture, that is a very serious situation. That is most infants with these findings are stillborn. That is what I already explained. What is the meaning of stillborn? If the birth of the baby has taken place and death has taken on the inside of the womb, inside of the uterus and the birth, but there is no signs of the life after the birth, then it is called as that is all the signs of the death which are present, then it is called as stillbirth. So it is more serious because it leads to this stillborn and associated with an extreme focal deficiency in the water study. And in monoamniotic twins, we are going to see about this twins. A significant fraction of the high perinatal mortality rate is activated to infilling of the umbilical cord before the labor is in monoamniotic twins. Then hematoma. Sometimes what happens that the accumulation of blood are associated with the short cord. If the what we have known that the length of the cord is less than the normal 50 to normal length is 50 to 60 centimeters. And what it leads to, due to the movement of the fetus, what it leads to the early separation of the placenta, that is abruption placenta. If it is associated with some accumulation of blood, so that may be due to some trauma and entanglement. So that is called as anatomy. And what is it is the result from the rupture of the varix region of the umbilical vein with effusion of blood into the that is abruption placenta. But sometimes there is also rupture of the varix and umbilical vein, and whatever the blood from it come out. So effusion of this blood into the cord, and it leads to the collection of the blood. So that is the hematoma, and it is caused by the umbilical vessel veniculture, that situation. And the umbilical cord cyst, that is the pathology which can take place. What is the cyst? It is the collection of fluid in the sac. And if it is fixed to the umbilicus, then it is umbilical cord cyst. And where it's found, it is found along the course of the cord. Where along the course of the cord, we see that. And there are again two types of cyst: true cyst and the false cyst. What is meaning of true? That is, it is an inclined remnants of the allantois coexist with the patent uratus. And in false cyst, it is due to the degeneration of vertebrae. Sometimes what happens, the covering around the umbilical cord, what it leads to, then it gets degenerated and leads to the false cyst. Single cyst may resolve completely, but sometimes if it is more than one, that is multiple cysts, it may be associated with miscarriage or aneuploidy. That can be, it means miscarriage means it leads to the abortion. So that is the risk of it. And sometimes umbilical cord position, so it can be to the presentation also, and it can be to the prolapse also. So types of umbilical cord prolapse, that is occult cord prolapse and inward cord prolapse. And sometimes there is a clinic presentation. Umbilical cord is called clinic. So if it is present, that is clinic presentation. That is nothing but cord presentation, and or nothing but the procubitus. All meaning the same. That is, if the what is meaning of presentation during the delivery, which part occurs the lower uterine segment. That is sometimes commonly it is the vertex presentation. But if other than that umbilical cord is present, then it is called as a clinic presentation, cord presentation, or procubitus. Nothing but the same. So what we see now? So this is the lower uterine segment. This is the normally vertex part is the same. But what happens over here? If you see, if this is the cervix part. If you do it, what we see? The umbilical cord is same. See in this diagram, here is also, this is the umbilical cord which is present. And this one is over here, the umbilical cord is coming outside of the vagina. That is cord prolapse. So these are the varieties, types of cord, umbilical cord prolapse. In this is the prolapse umbilical cord. So this is the fetus inside of it. This is the uterus, and this is the cervix. And from over here, what we are seeing the umbilical cord. So this is prolapse umbilical cord. And sometimes there is a rupture. So what is it? Ruptured membranes, occult cord prolapse, descent of the umbilical cord alongside, and overt cord prolapse, where umbilical cord past the presenting part. That is two varieties. That is the in occult cord prolapse, there is a descent of the umbilical cord. That is alongside. While in overt cord prolapse, umbilical cord past the presenting part. So clinic presentation, that is cord presentation and procubitus. So what we see in this, what we see that one or more loops of umbilical cord between the fetal presenting part and the cervix. And if the cervix is open, the cord can be easily palpated through the membranes. That is what we see in this. So no rupture membranes, that is tunic presentation, cord presentation, prophylaxis, one or more loops of umbilical cord between the fetal presenting part and the cervix. And if the cervix is open, the door cervix, if the cervix is open, the cord can be easily palpated through the membrane. So definitely, if you see for vaginal examination, so how we are going to see it, it is a pulsation. While in case of vertex presentation, for vaginal, what we see that it is the hard part what we are going to see with it. So that is how can we clinically judge it. And what is the etiology? An obstetric condition that predisposes to poor application of the fetal presentation part to the cervix may result in prolapse of the umbilical cord. So what is it? An obstetric condition that predisposes to poor application of the fetal presentation part. If there is some problem for the presentation of the fetal part, so that can be the cause of it. So predisposing factors, that is sometimes prematurity, sometimes abnormal presentations, that is if there is a bridge presentation, bro presentation, face presentation, transverse presentation. These are abnormal presentation. What is normal presentation? Vertex presentation is the normal. And other than this presentation part, then it is a bridge, bro, face, transverse, anything. Or sometimes there is a multiple gestations, that is it twins, example that you can think about. Then placenta previa. What is placenta previa? Where the placenta is present in the lower uterine segment. Or sometimes polyhydramnios. What is polyhydramnios? When the amniotic fluid it is more than 2000 ml or 2 liters. That is polyhydram. Poly means more than. Hydramnios. Hydramnios means amniotic fluid. And the premature rupture of the membranes. That is, if the premature rupture of the membrane can lead to, and sometimes if there is a length of the cord, it is more, that can lead to this condition. So what is the factors, basics? So that is maternal factors, what is, so that multiparity, that is the third or fourth pregnancy that you can think about it, or if there is a pelvic tumor which is present, or sometimes it is abnormal birth canal, that is what is the anatomy of the female genital growth. If it is not normal, can lead to this type of the condition. And heterogenic factors, that is artificial rupture of membrane with an unengaged presentation. If there is an engagement has not taken place, still if there is a rupture, artificial rupture of membrane, can lead to this condition. Now, how can we clinically going to diagnose this situation? That is overt cord prolapse. So, what we that visualizing the cord protruding from the intratus, second or third degree of prolapse. That is the, if you see inside of it is the cord, it is protruding out by speculum examination or by palpating the loops of cord in the vaginal canal. So that is if you do the by palpation, what we see that we feel that cord it is present. So that is first degree prolapse. And if it is clinic presentation, that is by speculum and bimanual examination. So that we can see that clinic presentation or cord presentation. Cord presentation, what we are seeing that there is a another name for it is that is prophylaxis. That is what we have seen this. So that what we are seeing. Then occult prolapse. It is suspected if the fetal heart rate changes. That is variable declaration. That is slowly it goes downward. Then it is we can think about it. That is clinically we can judge it. Due to intermittent compression of the cord are detected during the monitoring. But we see that sometimes there is a FHS, it is normal, then in between again it is get declared, again it becomes normal, again it gets declared. That is what we see, that is during the part of during the examination. So that's what we see that the FHR, fetal heart rate, it is get decreased in between. And why it is decreased in between? That is due to the compression of the cord that is present in between. So there is a FHR, it is plus minus, that is variable. That is variable deceleration. If compression is complete and prolonged, it induces asphyxia, metabolic acidosis, and sometimes it also leads to the death also. So it induces asphyxia. Asphyxia means oxygen supply to the fetus is not properly. Then the metabolic acidosis can it lead to, and sometimes it can lead to the death also. That is asphyxia, that is hypoxic ischemic encephalopathy, and cerebral palsy also can lead to. that is hypothesis. And the cause of asphyxia, that is cord compression, but obviously the cord gets compressed, that is, and whatever the preventing the venous return to the fetus. So whatever the, as we know that why venous return is problematic, because it gets compressed. And why veins are important? Because veins are carrying the oxygenated blood, opposite of it. So definitely, whatever the requirement of the fetus is not proper, and it leads to the problem of encephalopathy and the cerebral palsy. And sometimes there is an arterial occlusion, vasospasm, secondary to exposure to the vaginal fluid and or air, because when umbilical cord goes outside, so it gets exposed to the fluid and or exposed to the air. So it leads to the vasospasm. What vasospasm means? What is? It gets compressed, spasms, spasmodic stage, and arterial. So it can lead to this hypoxic condition and the encephalopathy and cerebral palsy. That is what we are saying this. And the prevention. So how can you? So if it is malpresentation or poorly applied cephalic presentation, so that is the US at the onset of labor. During labor, patients at risk for continuously monitored for abnormalities of FHR. So if you see that during labor, we have to monitor the FHR, that is fetal heart rate, and that avoid the amniotomy until the presenting part is well applied to the cervix. And at the time of spontaneous membrane rupture, a prompt, careful pelvic examination. That's what we have to follow it. And what is the management? Management, it is the venous access, that is the consent should be taken properly, and the immediate cesarean section and the manual replacement is not recommended. To prevent vasospasm, minimal handling of the loops of cord lying outside the vagina and cover them in a surgical pack soaked in a warm saline. So by avoiding the exposure to the air, what we can prevent the vasospasm and ultimately what we are going to prevent the asphyxia. That is what we have to think about. So now we are going to see about a little bit about the things. The types of twins, it is the because what we have used the word that is monozygotic, so I'm just giving this a little bit of introduction about the twins. So twins, that is the types of twins, that is dizygotic, that is fraternal twins. It is the commonest type as it represents two-thirds of the twins and 7 by 11, about 1,000 parts fertilization of two separate ova. Here, that is fertilization of two separate ova, and each embryo has its own placenta, chorion, and amniotic cavity. And twins are non-identical. That is not similar. It may be male if one is female, or non-identical, and may of same sex or different, or it may be of same sex or different, and it is non-identical one. That is trizygotic. And the monozygotic, that is identical twins. That is what I use the word monozygotic. Developed from the division of a fertilized ovum, twins of this type are identical, that is similar to each other, and having same sex. While in previously see here there is maybe same sex or different. That what is meaning of it? Both may be in dizygotic, one may be male or one may be female, or both may be male or both may be female. This can be happen in dizygotic. While in case of monozygotic, it has to be both to be female or both to be male. And the incidence wise, it is 0.3 to 0.4%. And division may occur at different stages, that is at morular stage, which is, has a separate amnion, chorion, placenta, that is, it may be that at that level, or it may be at blastocyst stage due to division of inner cell mass, which has separate amniotic cavity, but single chorion and placenta. And if it is sex has the division has taken place at the embryonic disc, then it is a midline division of the embryonic disc. Twins has a common amniotic cavity, common chorion, and common placenta. It is same in this. If it is morula, early blastocyst, and embryonic. In this morula, two cells is formed, morula cell division. So here it is separate amniotic cavity. Here it is separate one. Yolk sac is different, and how it is clinically formed. Here it is separate. This one is umbilical cord is separate. Here is umbilical cord is separate. Here is different placenta. Here is different placenta. while if the division has taken place in the early blast process. That is what we say this division, where the division occurs. Here, if this is two cells, cell junction, and if in this one inner cell mass, here is inner cell mass, here it is in the signal, whatever it is, common chorionic cavity, what we are saying this, chorionic cavity is common, and here it is the common placenta, but umbilical cord is here, it's two different. And in case of if the division has taken place and blastocyst, so it is the amniotic cavity, what we are saying in this, what is common chorionic cavity, common amniotic cavity. So here it is the partition is present, but in this there is no partition. That is what how can you see the relation where the relation of umbilical cord in case of twins. And what it leads to, this is Sannosi or conjoined twins, fused monozygotic twins that occur due to incomplete separation of embryonic disc. They could be either craniophagous, thoracophagous, and pyophagus. Means what happens? It is the fusion between two hairs, or fusion at thoracic region, or fusion at the pelvic region. So how can you say clinically this is the conjoined twins? This is thorax. Both are get joined together. That is what it is. Where there is a problem in the embryonic disc if there is a separation has not taken place. There is a fusion. This is pyophagus backside. And this is cranium, that is head arm joint together. So that is how can pyophagus that is also pelvic region. See, these are the conjoined twins. So these are the twins how it is umbilical cord that is related with what we have seen. So what we are seeing different abnormalities of uh, umbilical cord, that is from the lengthwise, again from the length that is long length and the short length, then what we have seen lengthwise abnormalities, then what we have seen about the cord wise and attachment wise, what we have seen is, then this is just short revision what we are seeing is, that is length, cord, attachment, knot, not content wise. So this is what is what we are seeing it. Abnormalities from the length, cord, then content wise, or sometimes core vessels, then cord insertion wise abnormalities, then the blood flow wise torsion structure, hematoma, and the cyst. And again, lastly, I have seen how it is in the twins. So abnormally short and long. Then the length, this is the umbilical cord coiling, this is the normal, this is of hypertony, this is of hyper, less hyper, how it is looks in the this sonography. Then cord insertion wise, it is the marginal, perfect, filamentous, and vasa previa. So this is perfect, marginal, perfect, marginal, and filamentous insertion. So that is what we are saying. Then this is the back-end door, that is at the corner. Then these are the filamentous placenta, vasa previa. Then this is how clinically this is Doppler scan to detect the vasa previa. Then let's what is the number point of view, content point of view, vessel number point of view, single umbilical artery, or sometimes there are four vessels called that may be the abnormality. This is the how clinically what we are seeing single umbilical content cross section on the umbilical cord. Then sometimes fused umbilical artery. Then knots. This is mitral anastomosis. Then knot. This is false knot. What we are seeing today, false knot. True knot. This is false knot. This one is true knot. Then loop one. to 3. Loop and types of loop, that is type that is sliding manner, and this one second one is sliding, that is locking manner. Then next one is that is what we have two loops which are present. Then sometimes there is a torsion and stricture. And hematoma, that is what presence of blood, collection of blood. Then presence of cyst. Again two types, true cyst and the false cyst. Then cord prolapse, that is occult cord prolapse, occult overt cord prolapse, and the presentation. So the presentation, cord presentation, and proctitis. Then image what we are saying, the prolapse of umbilical cord. Then what we are saying, the etiology, risk factor, management, how we are going to diagnose clinically, what it leads to. And this is one is the management, and the last part is thank you very much. So that's what we have finished about the structure and function of umbilical cord and the abnormalities of the umbilical cord and how it is going to present in the twins. In short, what we are seeing in the twin solution. So that is thank you very much.